everyone. Thank you for waiting. While people are coming in, I'm going to go over some housekeeping items. Please make sure, if you haven't done so already, to mute your line. We'll have time for questions and answers at the end. You can ask your question by typing a question in the chat box on the right-hand side of your screen. Please close any other applications or windows that you are not using to conserve bandwidth. This webinar will be recorded and uploaded to our website next week. I'm excited to introduce our presenters today. Dr. Elizabeth Painter is a clinical health psychologist at the Lewis Stokes Cleveland VAMC. She serves as a clinical instructor of medicine at Case Western Reserve University School of Medicine and is the Associate Director of Psychology for the Transforming Outpatient Care Center of Excellence in Primary Care Education at the Lewis Stokes Cleveland VAMC. She received her doctorate of psychology at Xavier University and then completed her internship and fellowship at the Lewis Stokes Cleveland VAMC. Dr. Painter has educational expertise in interprofessional education and shared decision-making. She has clinical expertise in cardiology and transplant psychology. Dr. Megan McNamara is a professor of medicine at Case Western Reserve University School of Medicine and the director of the Transforming Outpatient Care Center of Excellence in Primary Care Education at the Lewis Stokes Cleveland VAMC. She received her medical degree from the University of Pittsburgh Medical School and then completed her residency, chief residency, and fellowship in general internal medicine at the University of Pittsburgh Medical Center. Dr. McNamara has educational expertise in curricular development and evidence-based medicine. She has clinical expertise in women's health and LGBTQI issues. With that, I will kick it over to Drs. Painter and Dr. McNamara.
Hello, can you guys hear us?
Yes.
Wonderful. So we've had a little bit of a technological brouhaha today, so please hang in there with us. So we're going to get started today. This is Elizabeth Painter. I'm going to start the presentation by just talking a little bit about a program that Dr. McNamara and I work on here at the Cleveland VA Medical Center. I can't see the slide, so bear with us. So our first slide, Claire, as long as it's the interprofessional education slide with the picture. We'll assume so. So one thing that we've known for quite some time, or is at least well believed, is that there is a benefit to having interprofessional care when it comes to patient outcomes and professional satisfaction. What's been identified is that part of the issue with that is we tended to just put people into a room without actually training them to work together. And so as you see in this graphic, which is one of my favorites, it was put out by the World Health Organization back in 2010, which highlighted that the issue really existed in not training people to work together, but just assuming that they would be able to do so. If you could just move on to the next slide for me. So once we identified the problem, it became, how do we fix it? So this has been a conversation that's occurred across the country and certainly across the VA system. I think within the VA system, we've done integrated care for a long time. Within our VA here, in our primary care setting, we've had integrated psychologists at least since the 1990s, but we've always had more siloed education. So then the question became, what do we do next? You can move the slides for me. So back in 2011, OAA, which is the Office of Academic Affiliations, which is part of the VA that focuses on education and training programs for health professional students and residents in hopes of improving quality of care, decided that they were going to try and address this issue because, one, we need folks to be able to work in interprofessional teams, and two, there's really been a shift in medicine over the last years in terms of a lot of professionals are trained to focus on acute care medicine because you come in with a symptom, you get treated, you go on your way, you get discharged from the hospital. But on the flip side of that, we're now managing a lot more chronic disease and doing a lot more outpatient care, which requires a little bit of a different skill set. So driven by that new need, they were invested in trying to find other ways to teach our interprofessional learners. If you can move the slides for me. So what they were thinking was that we need to devise programs that really hit learning from different perspectives. So thinking about didactics, reflective practice, and also workplace learning. So trying to really come up with a comprehensive way to do this kind of teaching. And so they tasked several sites to develop an interprofessional curriculum that was innovative but included all of these modalities. If you go on to the next slide for me. And within that, they were really interested in focusing on 4 different educational domains that they thought were really important and integral to being able to do effective chronic care management, and effective interprofessional care. These specific domains, which you can see, are shared decision-making, sustained relationships, interprofessional collaboration, and then performance improvement. I've put the link there in case you have interest in reading about those things further, but those were things that they felt were the most important and needed to be focused on at each different site. Now, they were open to people doing innovative and flexible different kinds of training as long as they focused within those domains. If you could switch the slides for me. So what ultimately ended up happening is many different VA sites applied to participate in this program, and 5 main sites were chosen. They were provided with $5 million over 5 years to develop this new kind of curriculum. We were developing curriculum, testing curriculum, trying to figure out what's the most helpful in terms of helping folks be able to function in the setting and function well within interdisciplinary teams. After that 5 years was over, we got phase 2 of the grant, which then added on 2 more sites and provided each of those sites with $4 million for another 4 years to continue the work we were doing in interprofessional care and outpatient care. You could flip for me. So these are the sites that were affiliated with the COE program within the VA system. The original sites were in Cleveland, Seattle, Boise, West Haven, and San Francisco. And then on phase 2 of the grant, we moved on to add Houston and then Greater LA. If you can move forward for me. Just so you have a little bit of a sense of what our program looks like here in Cleveland, we have an interdisciplinary learner cohort. So we involve psychology, pharmacy, medicine, our nurse practitioners, and our social workers. This group of students all work together and train together. So that involves 4 hours every Friday morning. They come together for interdisciplinary didactics, and then they also work in a resident-run continuity clinic together, managing the same panels of patients. If you could move on to the next one for me. And when Cleveland thought about how they really wanted to structure these 4 domains that we were kind of assigned to work with our curriculum, when we thought about what was important in professional formation and being able to work in these settings, we identified, obviously, the 4 domains and then the 6 dimensions that we thought were the most useful. So you'll see them listed around the graph. So unified care, quality care improvement, real-time, real patient, proactive care, culture and healthcare, and virtual healthcare. Now, it would be a whole other talk if I go through what all of those things mean. But it's just important to understand that we thought about this very broadly and all of the things that we were trying to integrate into the curriculum. If you go to the next slide, you can see a really complex, really wordy slide that characterizes how we were thinking about curriculum. And what an important piece of that was when we think about social determinants of health. It was something that we felt was important from the beginning, and we had woven into our curriculum in very different places. So we'll talk a little bit about each of those different domains. If you could move on to my next one. Thank you. So within each of the educational domains, we had several different activities. We obviously weren't going to take you through all of them, but I wanted to highlight a couple of the different places where we purposefully integrated social determinants of health from the beginning. So when you look at our iTopic modules, these were based on what was previously known as the Yale modules, which are a progressive case conference that was historically designed for medical trainees. They worked their way through a case as it developed and learned about a specific topic each time. Unfortunately, we found those to be very medically heavy, understandably, and so we decided to transition what we were doing and make those interprofessional cases, and which were presented by interprofessional teams, and also included a lot of psychosocial context within those cases. If you want to go ahead and switch on to our next slide, please. Within our performance improvement domain, we talked about our QI projects. So these are interdisciplinary projects that are conducted down in the primary care clinics, where they're looking at systems-based issues or things that are impacting patient care. And they conduct quality improvement projects and then hopefully present them or publish them. If we move on one more. within our shared decision-making domain, we created a conference that we call our Aligning Care Options Conference. What that was a interprofessional case conference for what I like to call the pit of your stomach patients. So when residents had on their panel someone that popped up on their schedule that they felt overwhelmed by or didn't know what to do or felt like we had thrown the kitchen sink at them and that we weren't making good progress for their health outcomes, they would present this case to our interprofessional trainees and also consultants. By doing that, they got the perspective of many different trainees, and then were also able to come up with an actionable plan when they left. Oftentimes, we found that the issues that were most discussed in these conferences were not at all related to medicine, but were related to social determinants of health and psychosocial stressors that were impacting our patient care. And finally, within our sustained relationships domain, we wanted to talk a little bit about the original identity curriculum, which I'll turn over to Dr. McNamara in 1 second. But this focused this was part of a collaboration we had with the Natural History Museum here in Cleveland, and was sort of an innovative way we thought about social determinants of health. So I'll let her talk to you a little bit about that. You could go on to the next one.
Okay, so thank you so much for inviting me to talk. Again, my name is Megan McNamara. I'm an internist at the Stokes Cleveland VA. And I'm delighted to take this opportunity to talk about a collaboration that we made between the Center of Excellence here at the Lewis Stokes VA and the Cleveland Museum of Natural History. So you can see we have a nice picture of the Cleveland Museum of Natural History, and it is really a lovely museum. So it was a wonderful opportunity to rethink how we were teaching social determinants of health and reconceptualize a new framework. Next slide, please. As Dr. Painter already discussed, the Center of Excellence curriculum had many areas where we are already teaching social determinants of health. But as faculty, we wondered, do learners really understand the impact of their unconscious bias and stereotyping on patient care and outcomes, and specifically how those biases and stereotyping relate to healthcare disparities? We wondered if we really needed to make this more explicit rather than just weaving it into different parts of the curriculum. And that was the reason that we developed the original identity curriculum. Next slide. As we were conceptualizing the original identity curriculum, we decided to reframe one of our traditional approaches that we typically use for thinking about cultural competence as a method of teaching about social determinants of health. So, as you know, many educational frameworks teach about cultural competence through the framework of looking at a culture and noticing its differences and appreciating those differences, recognizing and appreciating the differences in various cultures. We wondered whether that categorical approach, the approach of focusing on differences, may somehow unconsciously reinforce biases and stereotyping that already exist in a learner. And so we decided to unpack that and really reverse the way we typically teach about this. So we focused on sameness rather than otherness, really prompting learners to consider what connects us all as human beings, and then help learners discover their own biases and discuss practical strategies for mitigating them. Next slide, please. This slide depicts the original identity curriculum in an overview form. The first 3 parts of the curriculum happen at the Cleveland Museum of Natural History, and the last part happens a week later at the VA. At the Natural History Museum, we have a 2-hour session with 3 components as listed, and then we go back to the VA 1 week later for a reinforcing discussion about how the concepts the learners found out about at the Natural History Museum apply to their everyday practice. Next slide, please. So this is a picture of Lucy. Cleveland is very proud of her because one of the scientists at the Cleveland Museum of Natural History actually first discovered Lucy. As you all know, Lucy is one of our early hominid ancestors, and so there's a large display at our Natural History Museum with her exhibited in a nice area with a glass case and as part of a evolutionary discussion. Next slide, please. This slide lists the 3 components of the curriculum that take place at the Natural History Museum, along with the topics covered and the facilitator. So I'll go through each of these in detail. The discussion about Lucy and the tour of the Human Origins Gallery at the museum are conducted by the Natural History Museum educational docent. So as we were developing this curriculum, we enlisted the help and guidance and support of an educational docent as well as an anthropologist who works at the Natural History Museum to really gain their insight into how these concepts could be taught differently. So the docent who helped develop this curriculum leads a discussion with the learners about the discovery of Lucy and how she's part of the overall hominid fossil record. She walks the learners through the entire Human Origins Gallery and ends the discussion by focusing on the migration of hominids out of Africa. And as part of that discussion, she really emphasizes what's called the bottleneck. So as humans were migrating out of Africa, there was a constriction and a bottleneck phenomena which resulted in 99% of the genetic DNA that we have as humans being the same. So that's called a bottleneck. After the learners tour the gallery, they then move to a classroom where they participate in an interactive lecture called Shared Genetic Heritage and Cultural Construction of Race. The biomedical anthropologist leads this conversation by picking up where the docent left off, again, focusing in on the fact that the bottleneck constriction that happened during migration of humans out of Africa resulted in significant genetic similarity among all humans. And that the reason humans look different in various areas is really a result of adaptation to environment rather than biological differences. And as part of discussing that, she really brings up the idea of race as a cultural construct rather than something that is rooted in biological differences. The last part of this series at the Natural History Museum focuses on patient case studies, and we learned over time that this is really an essential part of the curriculum in order for learners to think through how this new knowledge relates to their everyday clinical practice. As a practicing physician, I felt it was important to use cases that were similar to those that I saw in my own clinic. The first patient that we discussed is actually based on a patient that I saw in clinic, who at the time that I met the patient's gender, race, cultural background, and native language were ambiguous. And so I discussed with the learners how you approach a patient where the usual cultural constructs that we use to think through who a patient is were not there, were not readily apparent, and how you connect and communicate with that individual. The second example is a patient who's gender nonconforming and uses gender-neutral pronouns. Again, I provide care to transgender individuals. This is a patient who's very similar to someone I would see in my own practice. And again, I'm trying to help the learners unpack some of the unconscious biases and stereotyping that they may have about gender identity. Next slide, please. This slide really focuses on the educational principles that we used when developing the original identity curriculum. The educational principles that we really focused on were reflection, rethinking of our common cultural knowledge, providing real-life examples from own practice about how stereotypes and unconscious bias can influence care, and then very specifically role modeling. So during the patient case session, I tell the learners how I made missteps and mistakes in my own practice dealing with patients who are similar to those in the case, and how I learned and felt like I could get better. The next slide shows the results of 4 iterations of the educational intervention. This includes 29 learners who participated. We asked the learners, when thinking about the learning session overall and the 3 activities, please rate the usefulness of the session overall. That was a mean 4.4 on a scale of 1 to 5, 5 meaning very useful. Please rate how much your confidence increased regarding using the tools or skills from the session. 4.2 mean on a scale of 1 to 5 again. And if this session were recommended, not mandatory, how likely would you be to recommend it to your colleague? Again, a mean of 4.6 on a scale of 1 to 5. Based on these results, we felt that we were having some success with this curriculum, and we have continued it over the last several years. We've thought about how to bring aspects of this curriculum into other parts of the overall curriculum, and in doing so, we really thought about what seemed to make this particular curriculum successful for us, especially considering it touches on a difficult topic, such as unconscious bias and stereotyping, which learners may not feel initially very comfortable discussing in front of others. And we found that these 5 elements were key for success. So first, a safe environment. We take learners who are in their more senior level of training. They've been in the same group for many months and they know each other well. And then I am one of the faculty who leads the discussion. Since I'm their program director, I know them very well, and we feel comfortable around each other. Faculty role modeling we found to be particularly helpful. As someone who's pretty far along in their career, I think it's important to be able to own up that I can still make mistakes and I still have biases and stereotypes, and to think about how I manage them in everyday practice. And I really share that with them so that they feel that this is something they can discuss openly. The non-traditional learning space has been very important for us. We find that as learners leave the hospital setting and move into a setting which is not as familiar with them in terms of learning, they may open up a little bit more or feel a little bit more comfortable. And it allows them to remember that they are not just clinicians, but that they are humans, and that they have likes and dislikes and biases like all other humans, and so it helps to norm that. I already mentioned the importance of vivid, realistic cases. Learners are engaged if they feel like this is going to be something they see in practice, so we use real-life cases, and a small group size, of course, to encourage open discussion, so we never have more than 12 learners at any one time. And in thinking about the original identity curriculum and our overall Center of Excellence structure, we think that it's helpful to move from the approach of weaving discussions about cultural competence and social determinants of health into many areas of the curriculum, and to really move that into focusing very explicitly on terms such as unconscious bias and stereotyping to make it clear to the learners how these concepts relate to healthcare disparities. And so we have this picture here where we're, a weaving approach versus the Captain Obvious approach. And as an educator, sometimes I feel like if you want learners to really learn what you're saying, you need to make it as obvious and as explicit as possible. So the original identity program is an attempt to do so. So I'll turn this back over to Dr. Painter for the rest of the presentation.
And the timing of recognizing how we can use these different curricular innovations to be really explicit about teaching social determinants of health and other things that we were thinking particularly important fell at a really good time, in the sense that if you did some quick math while I was talking earlier, our grant funding for our COE program will be up this October. And we're very lucky to be able to say that the hospital is planning to fund our program as is, so we can continue having our learners doing the same kinds of didactics and working in the same kinds of settings, which is really exciting, and we're looking forward to that. But it also gives us a little bit of flexibility now, because we are no longer sort of dictated what educational domains we think are important or how we want to teach those things. So as we came together as an interprofessional faculty, we spent a lot of time thinking about what kinds of things are missing from our education or our curriculum, or what kinds of things need to be more strongly highlighted as significant points all on their own. So what we have come up with is we're actually going to add 3 new domains for our curriculum. Social determinants of health, obviously, as we were discussing, leadership, and professional satisfaction. Now, by adding those, we had to really think about how we wanted to go about teaching them and developing them. And so we just want to talk a little bit about what that process looks like for us. So if you could go to the next slide for me. The way we sort of conceptualized what needed to happen was a stepwise approach. So we first made a kind of a small subcommittee of interprofessional faculty to think about what's truly our vision statement. What do we want people to be able to see and do from our curriculum when we're done? And so what we've come up with so far, I feel the need to read out loud because we put a lot of work into it, is our current vision statement reads, and it's still a work in progress, to understand the interconnectedness of societal and cultural influences on the patient's interactions with the medical community, create awareness of how health policy, legal precedent, societal challenges, and environmental factors affect clinical decision-making. So when we think about what we really want this to be about, that's sort of where all of our brains went. The next step that we're going to work on is thinking about what our objectives are for the broad course. So we have learners that come in from anywhere from 1 to 3 years, as you saw in the previous slide, and thinking about what content they need over the course of their training and how to appropriately time and space that. So what we want to do next is develop the objectives for what that broader course looks like. Once we move on from there, we're going to look more specifically at the curricular design. So what each of the individual sessions need to have and what the goals are for each of those sessions. And within that, we have some option for tailoring and creating new teaching innovations. Things like our original identity curriculum will obviously fit within the course as it stands now, and then potentially give us the room to further elaborate and further create new things for our learners at that point. And so that's kind of where we sit right now in terms of what we're thinking about next for our social determinants of health curriculum and sort of how it evolved from a place where we initially had a curriculum that was trying to do a whole lot of things, but made sure that we had social determinants of health sort of woven within that curriculum, and then how it's evolved to a place where it's going to be a feature of its own where we can focus more explicitly on it. Okay, so if you go to the next slide, we have our question slide, which I appreciate, and we unfortunately can't see you, but would really appreciate an interpretive dance. But otherwise, we'll open the floor if folks have questions.
Thank you so much. First, I'm dropping the evaluation for the webinar in the chat box. This time we'll have time for questions, so please enter your question in the chat box and I will read it out loud so everyone's able to see it in the recording afterwards. We do have one question from earlier. Could the presenters discuss the cost, faculty time, resident time, operating costs, et cetera, of the program?
Yes, I assume you mean the original identity program. So it is costly. It was beneficial that we had a grant that we were working on to fund some of this. So in terms of the specifics, faculty time and faculty, so if you think about the faculty time, so conceptualizing the program took many hours. Once it was launched, and we're about 3 or 4 years into it, we do a continuous quality improvement of the curriculum in that we observe each other and see how things are going, but the curriculum has been largely the same for the last several years. So it's 2 hours every 6 months or so. The way our learners come through, we don't expose them more than once to this. So from a faculty time, it's not a ton now that the program is up and running. For the learners, it's the 2 hours in the Natural History Museum, an hour afterwards, and then there's about an hour of pre-reading before the curriculum is actually delivered to them. In terms of cost, that is an issue. It's a couple $1,000s, under $5,000 for costs, and that basically pays for the time of the Natural History Museum personnel to engage in this, as well as basically like taking up classroom space and museum space. Again, on the grant, we had the luxury of having money for doing that. As we move forward, we're thinking about how we'll maintain that in terms of a cost perspective. But again, once the curriculum is up and running, once we did all the pre-work to get it where we wanted it to be, the faculty time and resident time for maintaining it has been fairly minimal.
Great, thank you. Our next question is, I'm wondering how you define race in the curriculum.
So, Elizabeth and I were just looking at each other. I guess I just want to make sure race in the original identity curriculum is how I'll address it. So, in the original identity curriculum, we use what's called the biological anthropologic framework, which is a framework that anthropologists use to think about different cultural constructs like race and gender. So the way our anthropologist expert talks about it is really that race is a cultural construct. So when we link race to skin color, as she explains it to me, is really a biological adaptation to the surrounding environment. So skin color has nothing to do with underlying genetics. It has to do with how a human would adapt to the environment of more sun or less sun. So she conceives of it, and I think this is a useful framework, that skin color is biological adaptation, and that as human beings, we have overlaid race onto this biological adaptation as a cultural construct. So that's the way we're trying to peel this apart for the learners, thinking about what is true biology, how human beings are really organisms in an environment. Any organism in an environment will adapt to that environment in different ways, and then we as a society have overlaid our thoughts and interpretations onto these biological adaptations. So hopefully that's clear.
Thank you. The next question is, congratulations on such an innovative and engaging curriculum on an important topic. I am wondering specifically about the interprofessional aspect of the curriculum. What do you feel were the takeaways in terms of interprofessional learning?
So I'm trying to separate this out between our specific curricular innovation versus the program more broadly. I think some of our takeaways were in a place where I find, at least in medicine, that we have a very distinct hierarchy that we're working to kind of break down in some ways. And so I think one of the interesting things about doing this with an interprofessional cohort was that sameness piece was not only for patient care, but also sustained relationships within teams and amongst professionals. So I think that had kind of a secret hidden curriculum, if you will, part that went along with that.
Yeah, and I would add into it that really taking learners off-site sort of undermines that traditional hierarchy, right? So if learners are not in their traditional, hospital-based or clinic-based environment, and now we're in a natural history museum, and we're not necessarily wearing our white coats, there's sort of an evening of the playing field, so to speak, where learners are in a different environment, and what they're saying really may or may not have anything to do with their current profession, but really how they are as human beings. That's what we're trying to encourage. The non-traditional learning space, we hope, sort of implicitly levels the playing field from that perspective.
Thank you. The next question, what outcomes have you measured beyond the 3 scales, utility, likelihood of participation in the future, that you reported previously? Specifically, any skill or clinical process changes? What outcomes are you hoping to measure in the future? Okay, so in all honesty, that's part of what we're struggling with right now. And we'd appreciate any feedback on this, how measuring the effectiveness of a curriculum really results in behavioral change. And, this is the million-dollar question for everything we teach as educators. Will this make a difference in patient care? What we have done to date is to kind of get a proxy to that. So in that reflection discussion that happens a week later, so that the learners go through the 2-hour intervention at the Natural History Museum, then they go back to clinic for a week, and then they come back and they have really a focus group discussion
on what they think about, how they assimilated that new knowledge into practice, and how the session may have reframed their clinical thinking in some way. So we did start a qualitative research project on those, with the learner's consent, on those discussions, and we really found certain themes that came up. For the large part, learners really were able to incorporate some new thinking into their interactions. They were able to see how biases may be interplaying into their healthcare decisions. What we have not successfully done is taught them the skill set of how to manage those, because I think that's actually, you know, if we're thinking about patient outcomes, there's sort of the awareness and knowledge, which is what this curriculum focuses on, but then there's a huge piece that is skills and skill management. How do you manage those stereotypes and biases in real time? And then once you manage them, how does that affect outcomes? So it's that middle piece we're still missing, and that we're thinking a lot about what's the skill set that we need to teach and how do we teach it to actually affect patient outcomes.
And I think there's another piece of that in the sense that we are doing a lot of, like we talked about, trying to make things very explicit. I do think there are things kind of woven into our curriculums that demonstrate changes over time. We can certainly see differences from our first years to our third years. And I think anecdotally, some of the other activities we have the learners engage in, where they're doing reflections on interactions with patients or doing the case conferences and those kind of things, we see an evolution of the kinds of issues they're bringing up and the kinds of things they're identifying as problematic. And so I think in some ways we're at least planting the seeds so that those things are a little easier to access, if you will. And I think in those settings we've had some opportunity to be able to affect some change on behavior and give suggestions for management, but that's something we're working towards in terms of making those things really very explicit.
Thank you. Next question, was there a discussion of the use of structural competency as a model in the curriculum, or the impact of structural racism or other systems of oppression on health outcomes?
Could you repeat that one more time for me? I'm sorry.
Sure. Was there a discussion of the use of structural competency as a model in the curriculum, or the impact of structural racism or other systems of oppression on health outcomes?
Yes, I think that's something that is very much on the forefront of our minds, and if you may notice more pieces of that kind of in the vision statement of where we're planning to move forward. I think those are things that probably warrant their own sessions and their own discussions, and so we're in the process of developing things particularly to address structural racism moving forward. I can't tell you exactly what those are going to look like yet. We've got some exciting ideas, but that may be a talk for next year.
Thank you. We'll look forward to it. The next question is, what are your plans/thoughts going forward on training around SDOH interventions?
Well, I think that's a little bit what we touched on in the sense of, I think we have had pieces of that intertwined into different activities we've done, you know, through the course of our curriculum. And oftentimes our focus when we're doing things like case conferences and things like that, they often get very theoretical when you're talking about high utilizers or problematic patients and those kind of things. So what we've made an effort to really specifically drill down to each individual patient and come up with concrete management plans, because I think that's one thing that's often lacking in our education is talking about things in theory is great, but it's hard boots on the ground to figure out how to use those. So our intention is to make those things those skill sets even more specific and do training specifically around those without the context of the other activities.
And I think the benefit that we have of having an interprofessional residency and curriculum is that we have social work actually built into our curriculum. So in addition to having nurses and MDs and psychologists, we have a social worker who's one of our learners. And having that person in the room actually adds substantially to the level of discussion of social determinants of health, because frequently they know more about it than the rest of us do, and they really add to the conversation. As one of we also have a social worker as one of our key interprofessional faculty. She's involved in the social determinants of health domain. So always having that voice helps us design better curricula.
Yeah. It's interesting when we start putting these things together, because everyone comes at it on our interprofessional team from a very specific viewpoint, and I think we all feel pretty confident in what we're saying, but sometimes miss the bigger picture, and having the ability to put all of those minds in one place has really been a blessing in terms of thinking about a more well-rounded curriculum.
Great, thank you. Next question, how does the larger system model internal culture change and support individual clinicians' awareness, readiness to change, and an individual behavior change?
So as part of the Center of Excellence, so it's a large program in that there are many faculty involved in delivering the curriculum for our interdisciplinary learners. And we found that providing rich faculty development sessions is important for the faculty to understand what our learners are learning, and it also really role models for the faculty how to engage in interprofessional teamwork. So I direct the faculty development series for our Center of Excellence faculty. And we do many things during that series. The series meets twice monthly, so all of our Center of Excellence faculty have clinic blocked for 2 hours every month to come to these educational series. And these series focus on, for example, if you're an MD attending, what it's like to precept in a nurse practitioner resident and what skill sets you might need to do that. We also talk about teamwork and how we're approaching teamwork in the curriculum. We talk about ACOs, and actually we have 2 learners per year present their Aligning Care Option Conference to the faculty so they understand what we're doing. And actually then the faculty loved the Aligning Care Options Conference so much that they adopted it on their own because it really helped them think through critically all of the issues that are at play with patients. So that was really fun. In this current calendar year, we're going to be introducing our new interventions with social determinants of health. One of them is a session on the justice system and how that affects patients. So that is also going to be in the faculty development curriculum. So we spend a lot of time supporting the efforts we do outside of the classroom in the workplace learning by teaching our faculty, by role modeling for our faculty, and having that constant cycle of reinforcement and re-education with everyone.
Absolutely, because I think one of the fastest ways to break down didactic education is not to have it supported in the clinical environment. So we've worked hard to try and make that a supportive place where these things can be put into practice and where it can be done effectively on both the trainee and the attending level.
Great. Next question, how much curricular time do you actually devote or plan to devote to SDOH?
That is a great question. We have not figured that out. That is actually a charge. We have specific working groups working on each of these new domains, social determinants of health being one of the domains. And that is a charge of the working group to say per block, and for us a block is 12 weeks. So per block, how many hours of educational time do the learners get on Friday morning didactics? Per block, how is this reinforced in workplace learning? And then per their entire COE experience, what are the absolute necessities of what they need to learn about social determinants of health and how much time it is? So that is very much in development. As you can see, our curriculum is very complicated, so we have to be quite thoughtful about the time allotted and how it balances with other things. But as a group of faculty, we have really decided that this is an incredibly important part of our curriculum, and we're going to be focusing a lot of our attention on it. So that's an also to be determined. Maybe next year we can share. We're in the process of working on that right now. We do not have a hard and fast number.
Great, thank you. Does anyone else have any other additional questions? We'll wait a couple minutes to see if there's any additional questions before we sign off. In the meantime, I placed the link to the evaluation again in the chat box. You can please fill it out. We appreciate any feedback. Okay, another question, 2 questions. Can you think of how we can replicate this without having access to the Lucy exhibit?
Yes, we actually have given that a lot of thought, and we started to develop sort of like a guidebook or an educational manual for how faculty can do this. So I think, the key elements of what we talked about already, what were the key strategies for success? A lot of those we can accomplish without, so small group size, faculty role modeling, all of that is essentially free. I do think it's essential to take learners off-site. So, encouraging anyone who's interested in doing something like this to collaborate either with their natural history museum or their art museum. We've done interventions with the art museum too. I agree that that piece of it has been so unique for us. I think it is replicable, but I don't think it's replicable without taking out the learners off-site and putting them in a new environment and encouraging a new way of thinking. So almost every city has a natural history museum, so even if you don't have a Lucy exhibit, I am sure most of them have, a human origins exhibit where you can discuss some of these things.
Yeah, we're super lucky to have access to the experts we do at the museum, but I think the content could be covered by facilitators from your educational places. I think the other thing that's a benefit of taking people off-site, whether it be to an exhibit or somewhere else, is, I think about when I'm treating people who have anxiety, we treat them to manage anxiety before they're anxious. So they learn the techniques of anxiety management when they're not anxious. When they're in crisis, they know how to access it. And I think when we're trying to teach learners to really take a step back and think in a different way and reflect, by doing that outside of the clinic setting, they get a chance to really do that and practice it before they're in the chaos that is a busy clinic where they don't have time to stop and think. So when they do need to be able to do that, they can access it more easily.
Great, thank you. Next question, beyond interprofessional diversity, were there other types of diversity prioritized in the makeup of the curriculum development and implementation team?
Could you read that one more time?
Sure. No, you're fine. Beyond interprofessional diversity, were there other types of diversity prioritized in the makeup of the curriculum development and implementation team?
So I think the question is asking when the Center of Excellence faculty got together as interprofessionals, clearly it was a requirement that we came from different professions. What other types of diversity the faculty considered? I don't think so. The curriculum has been together for 9 years, so the faculty who are involved mostly are people who are really experienced in education and then come from the different disciplines. So in all honesty, I do not think the diversity of the faculty was necessarily considered. Dr. Painter, do you have a comment?
Not purposefully, at least.
Yeah.
I think we ended up with a fairly diverse group.
We
but,
did, yeah.
I don't think that was targeted initially.
Yeah. I think, now that we are really focusing on this, that is an important consideration.
Thank you. Are there any additional questions? Give everyone a minute or two if they want to type something.
And please let us know if we didn't answer your question.
Yeah.
Okay, thank you everyone for attending. Please make sure to fill out the evaluation. It's in the chat box. I'll paste it again at the bottom so everyone is able to see it. Thank you to our presenters, Dr. Painter and Dr. McNamara. We really appreciate this.
Thank you for having us.
Yes, thank you so much.
And yes, the webinar will be available online probably by early next week. We will we'll put on our Twitter page and include it in our newsletter going out at the end of the month. If you're not subscribed to our newsletter, you can check out our website at SDOH Education. I'll put it in the chat box as well, .org. And you can sign up and view our past webinars and newsletters there as well. Thank you again. And
it was our pleasure. Thank you.
Thank you, guys. That was great to have a discussion as well.
Thank you. All right. Goodbye.
Goodbye.
Bye.